regarding the Medalist trial with this same compound in MDS.
Thank you, Dr. Seensma. Good morning, everybody. As you heard, the Medalist trial is a randomized phase 3 study testing luspatercept compared to placebo, a double-blind fashion in patients with lower risk MDS with ring sideroblasts that are transfusion dependent. So as a word of background, for patients with lower risk MDS, anemia is the most common symptomatic cytopenia that we deal with. And for most of these patients over time, the disease becomes transfusion dependent. And with that comes the attendant complications of iron loading. So recombinant erythropoietins, or what we call the erythroid stimulating agents, or ESAs, are the first line therapy that we consider for patients with lower risk MDS, specifically those without deletion 5q. And for patients who fail those or are intolerant of those or are unlikely to respond, we have a limited number of choices of drugs to offer. So luspatercept, as you just heard, is a first-in-class erythroid maturation agent that's under development for the treatment of patients not only with beta thalassemia, but also MDS-associated anemia. Luspatercept is a soluble receptor chimera that binds to an array of TGF-beta superfamily ligands to reduce aberrant SMAD2/3 signaling, and as a consequence of that, enhance late-stage erythroid maturation. In a large phase 2 study that was done in Europe, testing luspatercept in patients with lower risk, patients with MDS and symptomatic anemia, patients with MDS and ring sideroblasts had a higher response rate. And that was the rationale for studying that subset of patients in the Medalist trial. So as I mentioned, this is a double-blind phase 3 study. Patients that were eligible for this had to have a diagnosis of MDS with ring sideroblasts, defined as either 15% ring sideroblasts in the bone marrow or greater, or having 5% or more ring sideroblasts with an SF3B1 gene mutation. They also had to have lower risk MDS defined by the IPSS revised criteria, including both the very low, low, and intermediate risk categories. They also had to be red cell transfusion dependent, receiving at least 2 units every 8 weeks in the 16 weeks prior to randomization. And they also had to have less than 5% bone marrow blasts. And finally, they had to be refractory to or unresponsive to ESAs or not good candidates for ESAs based upon transfusion dependence in a higher serum erythropoietin level. Patients were randomized in a 2-to-1 fashion to receive luspatercept, beginning at a dose of 1 milligram per kilogram subcutaneously every 21 days, or to placebo. And the dose of luspatercept could be escalated during the treatment to as high as 1.75 milligrams per kilogram every 21 days. The MDS disease assessment was performed, as well as response after 24 weeks of treatment, and then every 6 months thereafter. And patients were followed for at least 3 years after their last dose of treatment for AML progression, as well as their subsequent treatment and overall survival. The primary endpoint for the trial was red blood cell transfusion independence for at least 8 weeks or longer within the first 24 weeks of therapy. Some of the key secondary endpoints included red cell transfusion independence greater than 12 weeks in the first 24 weeks and also within the first 48 weeks. Some of the additional secondary endpoints was erythroid hematologic improvement, defined according to the International Working Group criteria of 2006, which includes a reduction in transfusion burden by 4 units or more every 8 weeks in patients that are heavily transfusion dependent, or a mean hemoglobin rise of 1.5 grams per deciliter over 8 weeks. We had 65 centers that participated, enrolling patients between March 2016 and June 2017. As you can see, this included the United States, Canada, and centers throughout Europe. So as you can see, that there was a greater portion of patients that achieved red blood cell transfusion independence, the primary endpoint. 58 of 153 receiving luspatercept, or 37.9%, compared to 10 of 76 on placebo, that's 13.2%. And it was highly significant with a p-value of 0.0001. I might point out that patients on the placebo arm that responded had a very low transfusion burden at baseline, and they exceeded that 8-week threshold for response simply by virtue of changes in transfusion pattern compared to baseline. For the key secondary endpoints, overall 28% of patients on the luspatercept arm achieved red cell transfusion independence for 12 weeks or longer. On the placebo, that was 6 or 7.9%, and again, that was highly significant. And also, overall, about 52.9% achieved hematologic improvement, as I mentioned the definition earlier, with luspatercept treatment compared to 11.8% on placebo. I did mention that the median rise in hemoglobin in patients that achieved transfusion independence was 2.55, reaching as high as 4.1 grams per deciliter. This was a very clean drug and very safe drug. There were no differences in treatment emergent adverse events and absolutely no differences in severe adverse events or the frequency of progression to AML. So in conclusion, treatment with luspatercept resulted in a significantly higher portion of patients who achieved red blood cell transfusion independence compared to placebo, as well as erythroid hematologic improvement. It was very well tolerated, and those responses were durable, with approximately 40% of patients remaining transfusion-free after 1 year of therapy. So luspatercept is a potential new therapy that we think could be very effective in patients with lower risk MDS, with ring sideroblasts who are red cell transfusion dependent. Thank you.
All right, thank you.